So I thought we'd start with splinting first, and I've got recommendations to do a thumb spica splint, maybe an ulnar gutter splint, above elbow, sugar tongue for the arm. You guys want to see leg splints also?
Sure. Yeah.
Okay. I think one of the take-homes of doing this for you guys and for our own residents and anybody who is going to see kids is to make sure you don't get a heel sore, and so, which is just a really bad complication. They can take a long time to heal. And so when to put on the right kind of leg splint and for what injury was one of the things that first PowerPoint was trying to get across for you guys. So we can show you how to do that the right way. Okay, we'll do a thumb spica splint. Okay, this is really straightforward. Yeah. And this is, I'm gonna put my right hand so everybody can see it. So this is for somebody who's got either a known scaphoid injury or base of the first metacarpal injury, or they have snuff box tenderness and you don't really know if they've got a scaphoid fracture, wrist fracture, anything that's not just a standard only distal radius fracture kind of thing. You want to immobilize the first ray, and this is how you do it. So we usually put a little bit of cast padding under splints when we do it, but you don't have to. This stuff has got padding on it. It's just, it gets wet to make it dry fast, so sometimes having padding under there is nice. Do you want to see ulnar gutter splints? Do you guys do a lot of those? For boxers fractures or anything?
Yeah.
Good.
I don't know where to put garbage.
Can you grab the garbage down?
You might need like a big garbage
big
bin,
one.
actually.
Let's use one of these boxes.
I always peel this apart a little bit so you can cut any of the exposed, because if not, parents come at you and say we're hurting their kid.
Yeah, just cover however you do it, just cover the end of the fiberglass.
It's hitting for her. Yeah. Of course, dip it. However, you guys. You dip, put towel.
So you fill up a sink,
Fill the sink.
Yeah, I just run it under.
run
Yeah,
it under.
and then wring it out real well. In the OR sometimes we use when we do these for elbows and stuff, we use a towel, roll it up in a towel and step on the towel to get as much water out of there as possible. I don't know that you have to do that if you can wring it out really well. I just lost my train of thought. Anyway, it'll come back. Keep going.
So you want to get soaking wet and then as dry as you can.
Yeah, oh, water temperature, sure. Fiberglass, you want tepid water, right? Room temperature at the most. If you use hot water with fiberglass, you'll burn somebody because it gets very hot as it cures. You probably already know this, but plaster is completely different. Plaster, you use water basically as hot as you can get it because it's not as big of an exothermic reaction. So cool water is what you want for this.
Some kids, if their arms are big enough, you can go this way. If they not, you can actually kind of curl it. But keep it kind of locked in. So whatever works best for the kid.
And try to immobilize it in this position. So like they're holding a can of Coke, right? Instead of this position, this is A, not as comfortable, and B, it's harder to splint. So just have them sit there if they're old enough and pretend like they're holding on to a glass, and that's the position you want it in. And once this is dry, this twist maneuver right here, this is perfectly adequate for thumb injuries. Just kind of hold it while it's drying.
How long does it take to hold it there?
It depends on your temperature of your water, but
Probably 2 minutes
yeah.
to get it really good so you don't just.
How long did you say?
About 2 minutes.
And I don't know if your experience is like ours in the sense that we put on so many casts and so many of the kids are hurting quite a bit because they have fractures that were reduced and it's a big deal. And da, da, da. We always have 2 people when we're casting. Probably splinting is a little less important, but smaller kids need to be held by somebody or have somebody who's not doing the wrapping, making sure they're staying in one position so that you don't have, the thing about fiberglass is if they move when the material is still wet, you'll get a big fold and then you get a sore, and you don't want that, right? Plaster is a little more forgiving that way, but especially when it comes to casting, once you start laying down the fiberglass material, they have to stay in the same position. So we always have 2 people doing casts.
Nice.
Any questions with this one?
So you're saying if they're big enough, you don't wrap it around, you just go right along the edge.
I just don't fight it, you know, if not, then you're getting them over here and here, just kind of get it locked in the spot.
And then let it go where it goes.
Yeah.
With most kids, wrapping it around usually is what you have to do. But yeah, the older you get.
You're just focusing on locking that thumb at the wrist.
You're just there.
Yeah, and either way works. This I think is easier.
The thing is, they like to drop here, so having a holder, like, so they don't owner deviate. Sometimes you can make them do this and have them like look at it, so that they, you know, they're not going here or here.
Yeah, good idea. Are for forearm and wrist injuries. They are not for elbow injuries. Okay, they don't adequately immobilize the elbow, so even with a splint. So this is for forearm and distal. And the key here is to make sure you immobilize the wrist, but don't come too far out on the fingers. So I rarely get the length right on the first shot. So. We're gonna wind up reusing a lot of aces on here too. Let me see what I got. So this is a really good one to have somebody holding for you. So normally the kid would be on their back, somebody's holding the fingers, holding the arms, so they're not doing this and moving around. Depends on the age, but you can see that I got that a little bit too long, so I'm gonna actually do the cheater move and come in here and cut it out. Do you have buckets of water from when we start putting casts on? I don't need it now, but I was just thinking about that as I was doing it. So again, I'm getting the other cheat way to get in the oar, we just tug on it real hard. Mostly because it tends to already be starting to get hard, but so elbows 90, you're coming like this. You can fold, so most of what's folded over in this case is just the padding, okay? The fiberglass actually ends right at our MCP joints. Same thing back here. So the fiberglass is ending right here. So it's immobilizing her wrist, but she's still able to use her fingers. We see a lot of kids come in with their whole hand splinted, and you know, is it the end of the world? No, but they get awful finger jam in there, and then they take the splint off, and they're stiff, and it's gross. So, and we got it wet. I do not cut a thumb hole. So some people you'll see will cut a hole in the ace wrap for the thumb. We teach our residents not to do that because they get a really bad sore when they swell against it right here. So I think what the better move is to do this and to do it a little bit loose right here, because the other place they'll get a sore is right here on their thumb if it's too tight, right? So this doesn't have to be super tight, it just has to keep it on there, right? And then make sure you're up past the elbow so it's not doing that funky thing like this, if you can. And that's pretty much all you have to do. And if you're molding for a distal radius, you know, if you need to do something to mold it, you just kind of give it a little bit of forward usually. But I always like to make sure the thumb has enough room to move, but the wrist is still immobilized. Do you guys see that?
Mm-hmm.
So they can pretty much make a fist. This will become important when you put casts on as well. And then usually you supplement this with a sling. And the trick with a sling is most kids come in, if you put a sling on them and no safety pin, they come in, the sling's on the back of their neck. So if you're gonna use a sling, put it in, put the elbow all the way into the sling, put a safety pin right here to pin the two pieces of fabric together so the sling doesn't slide around. That's a good trick.
Can you just go over when would you use a short arm versus a sugar thumb? What are the different-
Boulder slab, you mean? Or cast, short arm cast.
A short arm splint, if you're gonna splint a short arm splint versus a sugar thumb.
We don't do a whole lot of, and our residents don't either, do a whole lot of just Bowler slab orthoglass splints. I think for like if you were in a situation like a buckle fracture and you didn't have a brace, and brace is your first move for that, right? But if you didn't have a brace, a Bowler slab would be fine. Some very, very stable distal radius fracture would be fine to do that with. You wouldn't want anything that was, dubiously stable to be in something that was only one side, which is where you get that in.
So almost everything else would be sugar thumb.
Yeah. We use these pretty much exclusively, but a volar slab is okay for the very stable distal radius injuries. You wouldn't want to use a volar slab for a forearm injury, so it'd just be wrist.
Okay.
So let's reuse this.
Yeah. Any questions on the sugar tongue? When to use? Okay.
So that's interesting. You don't put anything between the thumb and the pointer. You just leave that open.
No, I've seen
They
two.
move
I've
so
seen.
much, it just, we're peeling it out of them.
Yeah.
That's
I
great.
don't- And if you put padding here, it's gone by the time they, 2 days later. So I just have seen so many sores right here
Yeah.
and here that I'm really cautious about using.
Seems
those
way more
sores.
comfortable for them just to be
Yeah.
free with that.
But you have to make sure it's tight enough at the fracture.
So they're
that
not slipping out.
Windshield wipering around all over the place. It's kind of the take home with a cast too. You want to have a good mold on your cast, otherwise it's like a tube and it just slides off, right?
What do you like for super conduit?
Posterior, that's next,
Okay.
not this.
Okay.
Yeah, don't do this.
Sometimes you'll see like a combo, you'll see sugar tongue and like
Yeah, Dallin was just talking about that. I think for a supracondylar, that's overkill. I think if you do a good posterior splint, and the error with posterior splints and elbow fractures is not getting them high enough, right? So if you do a good posterior splint that comes high enough and do a sling, you're not gonna have trouble with them moving in it. And then the sugar tom becomes superfluous. The only time we ever do those in the ER is with montages, where you actually really have to control rotation of the forearm as well. Yeah. You can almost use that for a posterior. You're like, yeah, okay, hurry up. So this one for sure you want to do supine with somebody holding the arm. So I'm going to cheat. Again, important part is it's immobilizing the wrist. Breathe small enough you can use a 3-inch. Very few kids will need a 4-inch. Little kids you can use 2-inch for this. So
normally she's laying on the ground with her arm up in the air.
normally she's laying on the bed. One person's got her arm so it's not doing this, and the other person's wrapping the thing on there.
Okay.
So the key with these is to make sure they come high enough. So again, I'm covering up the bad end of this stuff. So you can always fold. It's not death to fold the top of that. It's just style points, really. So elbows need to be splinted. Supracondylars, type 1 supracondylars need to be splinted right about 80 to 90 degrees, okay? Don't splint them at this. And this is why you have to hold them until the splint's dry, because if you walk away, they'll extend their elbow and then they do wind up at 60 degrees. So you're making sure it stays right behind, your holder's making sure you're right at 90. Getting it all covered, getting it high enough.
What's high enough?
So when they're sitting up, I ran out of H rep, but pretend that's covered. So when you're sitting up, that's probably a little too high. Let me show you high enough. Got armpit level, maybe a little higher. So it's sitting in the back holding the elbow. You just don't want it to end here.
Yeah.
Right? We see a lot of those, and with a supracondylar, if they're in there with no block to movement back there, then they come in and they are sliding out of the splint. So keep it at 90, keep it high enough.
Would you
Immobilize
need
the
X-ray
wrist.
afterwards to see if it's when would it be like? And the providers probably know this already, but when you would refer them to a hospital, would it be when traction was needed?
Just a variety of reasons. Yeah.
Yeah, I mean, we do x-rays after splinting, after casting. We don't splint fracture splint, but we do x-rays after, usually when we've reduced or molded on a both bone or a tibia and want to make sure the alignment is still good. We don't often do it.
Okay.
Because you're generally for stuff you're splinting, you're working on your initial injury films. So,
And are you over the wrist there?
yes. Wrist is here.
So immobilizing the wrist and the
Yeah,
elbow.
and
Those two.
stopping shy of the metacarpals, so they still have good hand motion. But if you stop shy of the wrist, A, it hurts because they sit there and do this, and their hand also swells.
Hmm.
So,
Is there a secret to keeping where the elbow is, those folds that you'll get on the outside, or do we need to worry about those, or?
no, you don't, and you'll have padding underneath, but usually you're using padding underneath this. I think the other thing too is you tend to get those when you're using a size of worth glass that's a little bit too big. But the flip side is you don't want one that's too small because then it will be weak, right? Ulnar gutter is for usually fifth or fourth metacarpal fractures. Finger fractures, maybe proximal phalanx or MCP joint dislocations, but I think those are pretty rare. I mean, usually it's somebody hitting a wall and they've broken over on this side right here. And I think the key thing with these is to go to position of safety is the way I learned it in residency, and that's just a way to make sure you don't get tight. In kids it probably doesn't matter as much, but it also happens to keep the splint on really well. So your little bit of wrist extension and your MCPs are flexed about 70, okay? So it's not this, it's position of safety. It's kind of a back and a forward. So,
This is where I gotta ask you.
yeah.
I
Do
put it
you
here.
use for phalanx fractures too? Phalanx fractures?
Yeah, I mean, proximal phalanx, you could do that way. I tend to just buddy tape finger fractures most of the time. I don't know, what does Scott do? Our PA sees most of our finger fractures, so.
We just do a single side, aluminum foil.
Yeah, aluminum.
Cut them, yeah, cut them and wrap them.
Yeah, just aluminum finger splint kind of thing. Something where you don't have to immobilize the MCP maybe. But I think buddy taping as a rule is good for most finger fractures. I don't know what level of finger fractures you guys are seeing in the office most of the time, but. So what are you thinking of specifically for injuries that you want to know about?
Like the Montasia probably
Montasia.
needs to be seen
Yeah, needs
face
to-
up.
Yeah, those do a lot better when they're reduced right
Yeah.
away.
Yeah.
Anything besides a type 1 supracondylar.
Anything
Right.
besides the type 1 supracondylar. Radial neck fractures that
Mhm.
aren't nice looking, that look like they are borderline needing to be reduced.
Okay.
Our criteria for what's acceptable for those is tightened a little bit. We used to say kids under 8, it could be 50 degrees or more, and now we're more like 30. So 30 degrees is kind of our max angulation. So,
I had to ask her because this is a trick that I learned. That I just wanted to make sure, because we don't do this a lot in our office. But I mean, you could do that, but then you fight the ripples. So I like to cut it in a Y.
oh yeah, I've seen you guys do this. I have a non-kid size hand, so.
It gets a little trickier because you can't really cut that too much, but you could mold it, cover it in moleskin, and then it's comfortable for them.
So keeping the raw edge of the fiberglass off the skin.
You can try pulling it to fully cover it. But you kind of run out of time because they're done.
Okay. So here I am, position of safety.
I'm covering those. I have it on the back side. And running here. Someone would help me hold. But if I turn those this way, then I avoid that getting at them anyway.
Hmm.
It's okay. I'm just 5'4".
As I'm watching it, Drew. And using a smaller A strap is also a lot more helpful for this. It's not to keep going with it. Like a 2-inch. I would use a 2-inch for this.
That way you're not digging into there. So if someone's holding for you, they can kind of keep these positioned for you. She's trying to help hold, but she's spreading.
Because I can't multitask.
So, and you have time, so you can kind of lie it down, kind of get it just on. So that's all tight. Then you can kind of come back, make sure they're not deviated either way. kind of bend back at the wrist a little bit and kind of put your mold here. They're not gonna like you to mold here. So you kind of put it back of the wrist, kind of just help forward and pull back. And just hold it there till it hardens. Those ones like to move a lot too if you don't hold it long enough.
This isn't wrong for phalanx fractures, you know, initially. It's just, it's a little bit of overkill, I guess is the way I think about it.
Yeah, we
If
have
it's-
a fracture book that tells us what to do, and for proximal phalanx fractures, it says to do an ulnar gutter on those 4th
Yeah,
and 5th.
yeah, it wouldn't be wrong. It immobilizes the MCP joint, so with the proximal phalanx, we're probably a little more comfortable, so.
We tend to switch them out to only like to end here.
Oh, just shorten them. Don't go past the wrist, is what you're saying.
So you can see here, with a smaller ace wrap, you'd see it a little bit better. So position of safety, I'll kind of rotate it around a little bit. It's just covering the ulnar side of my hand, so you've got all this business, which is much nicer than a cast.
How long does it take to cure?
When you put water on it, the stuff goes very fast. We're not using water. So.
I know.
Yeah.
But
I mean, just air-wise.
Yeah.
you're talking about holding it at 90 degrees,
Yeah.
and then you were holding it, and I was like, how long do I need to stand there?
About 2 or 3 minutes.
Okay.
Yeah. But again, you're molding it till it's dry, because as soon as you walk away, a kid's gonna do this, right? So,
Mhm.
yeah. Legs are a little more, it's not that the leg splints are hard to do, it's that your choices are basically posterior, include or don't include the foot, and then a U splint, right? It's the issue with leg splints is when to do what, and how to avoid a heel sore. So the ones we see, and the ones you guys probably see the most are toddler's fractures, right? So tibia fractures. Boot those. If it's a true toddler's fracture, put a boot on first. That's your first choice, okay? And if you need to splint it, you can. But
A
those
toddler's
are-
fracture is a distal tibial fracture that's not displaced. Or,
Toddler's fracture? Yeah. Or even just by exam, you know, tender on the diaphysis where their x-ray is normal. So, if you have a tibia shaft fracture that's just a crack, it's more than a toddler's, but it's totally stable, non-displaced. Try to treat those with just a stirrup splint, okay? Try not to put anything behind the heel with those until kids are about 12 or 13. And the reason why is they get these posterior splints behind the heel, get these terrible heel sores unless you're really, really, really careful about keeping their ankle at 90 degrees as you're putting it on. And even then they can still get it. And kids who are younger aren't able to verbalize that the pain they're feeling is coming from a heel sore that's starting versus the fracture, right? And it's terrible. So we're doing an initiative with IHC right now to try to have the urgent cares around the valley learn to put splints on. But I just think in any way that you can stay away from doing a posterior behind the heel splint, you should do it. So proximal tibia fractures on the trampoline, you guys see that? Yeah, go ahead.
Just a question, I don't know if it's dumb or not. We have a lot of like boots that we can put, you know, kids with toddler fractures in. Could you comment on like the benefit of a splint versus a boot, if one's for?
Boot is better.
Oh.
Yeah, absolutely, yeah. So, and there's great data actually coming out that boots are fine, but actually doing nothing for toddlers fractures turns out to also be fine. So there's 3 papers that have come out in the last 3 or 4 years that show nobody displaces, everybody limps for about a week and a half, and then ultimately they do fine. So if you can also ignore a toddler's fracture and it turns out to work.
The slides that Mitch sent today from Dr. Fuller, like talk a lot about.
Yeah, I was trying to.
From your aid.
Yeah, I was trying to get everybody in that audience on board. They're like, yeah, no, it does. I will tell you, having done it a few times, it takes a little bit of hand-holding to talk them into doing nothing. But the parents that have done it have been happy, actually. So let's pretend you're a 6-year-old with a mid-diaphyseal crack in your tibia that's not really a toddler's. But we're gonna do just a sugar tongue splint, okay? Grease sock is doubling for the padding that you would put underneath there. Yeah, if you have a boot or a brace that fits anything that is indicated for that, use that first, for sure. So a U splint or a sugar tongue below the knee is just this. And again, I'm gonna trim it, so, but you want to make sure it ends, you know, here's the tibial tubercle, so right about there, maybe a little bit below, but you don't want it to be too low, especially if it's a mid-shaft tibia, right? You want it to come up high enough that it's getting the lever arm that you need. You also want to make sure it comes out and your heel is free. I don't know if you guys can see that back there. So you're not putting this behind the heel. You're using this to keep the foot up. And so as you're putting it on, you want your person who's holding to make sure they keep the foot neutrally dorsiflexed.
Is that what you meant by float the heel?
Float the heel means they don't let the heel rest on anything when they go home. So it's an instruction to the family. So when you're in bed, you put pillows behind the leg, leave the heel free. Yeah. It's also an order we put in inpatient orders for nurses to make sure they float the heel. Trauma patients especially will get heel sores because no one's paying attention to the splint on their leg, you know? They got so much else going on. Okay, so that's basically it. And again, if you use a big, so if I'd used 4-inch on her, that's where you're gonna get more wrinkle of the fiberglass, right? 3 inch is a good size for her, and it is for most kids. Little kids, you can use 2-inch. So, I mean, that's pretty straightforward. What else can you use this for? Ankle sprains. If you don't have a boot, you can use it for distal fibula fractures if you don't have a boot. Ankle fractures that need a little more stability is where this gets a little bit interesting because you do need something a little bit stronger behind the foot, usually. If you need to add a posterior splint, just make sure their foot is at 90, the ankle's at 90, and make sure you don't over pad the heel, right? If you have a ton of padding, like 8 layers of padding behind the heel will actually move more than if you just have 3 or 4 layers. So not over padding is one of the messages here, okay? So if I were going to do that, I would you can either do below the knee or above the knee. So if you have a more proximal fracture up here and you'd really like to mobilize the knee, you can add your second piece starting above the heel and going up to the back of the thigh. So that's for like a proximal tibia fracture. But if you really just need to immobilize like a Salter 2 distal tibia fracture, it's just fine to go below. You just got to make sure their heel isn't over padded. So you're going to go place where you really get into trouble with a heel sore and splint material is if there's too much padding, but also if they're not at 90. So if they're plantar flexed to begin with in the splint, it allows motion, and that's where the back of the heel starts to rub against the material, especially when they're in bed and their heels hitting the bed. Does that make sense to you guys? So you could just add this right like that and put the A-strap behind it. Just make sure it's centered. So I would do this, and then I'd put the A-strap on and do the whole A-strap on top of the whole thing.
One A-strap on top of
One
both.
A-strap on top of the whole thing. I'm just showing you just in case you wanted to add it. And again, the wider stuff you use, the more likely it's going to wrinkle around the sides of the ankle. But it turns out not to be as big of a problem as you think. So, okay, we just do one posterior splint.
Okay.
Starting high, you don't want to end here, that's bad, right? So start high and bend their knee about 30 or 40 and end right at the Achilles. And that's plenty for that. Yeah.
For a proximal tibia.
For trampoline, proximal tibia fractures. Yeah. What are you guys casting in the office? Give me a feel for it.
Mostly below elbow. That's it.
Mostly below elbow?
Yeah.
And is it mostly like stable radius fractures that aren't going to swell or have gone past their swelling kind of thing?
Parents who don't believe that the brace is enough for a buckle. Yeah.
Despite the myriad studies that show that that's true. Yeah, I think I should sit. If I sit, can you guys still see me? So again, we always in our office put these on with a holder. So somebody's holding the arm, making sure they don't move. A lot of the time, we are doing it for a distal radius fracture that has had a reduction. And almost always those want to come off radially and dorsally. So to counteract that, you do a thumb hold as you're putting it on and you give it a mold. For your purposes, I don't think it matters that much. So you don't have to stress about it the way we do. You can just have somebody hold the fingers because it's a lot easier to work around someone's fingers. So I'm going to pretend like that's what we're at. So Bree cut a little hole in the stockinette right there. And you just want a little bit of a nick because it gets bigger as you put it on. And notice that she left a big chunk of stockinette here. Do you fold over the top like I do? Or you make a second hole?
Nope.
Okay, she's going to show you something different, but
I
I
can
do
do
a
it
thing. I do a thing where I cut a second hole and fold it over. She's going to show you her way.
I can show both. It will be alright.
And gross ocean stuff.
So one way we kind of go around the thumb and the wrist. You just use a little piece. You have your padding. I put a hole in there.
Oh, that's cool.
And then come through here, through two. I tend to pull up a little bit, so I'm not getting a whole lot.
You don't want a lot of padding where the fracture is, because especially if you're going to put a mold on it, it'll make it hard. So you get layers of padding where you're going to fold it over. So like here's your other place, you get a few extra layers. One of the errors with these casts is coming too short, so you want to bring your padding basically to your elbow pit, right? Anacubofossa. And at the end of this, I should be able to make a fist. This is important, especially with older kids.
Do you want cast tape?
It should be in that gray bucket, or it was at one point.
So you guys can get the other side on this.
Your favorite
So
color.
she's got some padding around the thumb. This all dissolves eventually, but it's nice to have it there while you're doing the fiberglass. But
You also don't want to squeeze these.
You don't squeeze it?
Some people fold, make it pretty. I twist.
I'm gonna do this with my arm.
So I just twist. I'm pushing here. I'm not like diving in. You don't want that right there where they'll get another sore. Don't pull heavy there.
You just have to pull enough on fiberglass to take the bias out of it. You don't wrap it real tight. But to get it to do what you want, you have to pull on it a little bit. So now it's still tall. There's my elbow. So it's still tall and I can still bend my elbow, but it's not too short.
So you fold it over the stocking and the padding.
Yeah, we do like 1 or 2 layers. It's sort of when you run out of your first roll of fiberglass, really.
So when I do this part, I pull it down.
It's a good trick. I like this.
You can fold it
It's
over
better, it's better than my trick.
Or
Can you
you
do that
can,
again? I was looking at.
yeah. So
My eyes are closed.
pull it down here, here, and then you just kind of cross over.
So that's why you leave yourself enough room with the stockinette up here.
What's holding it there? Is it just?
Her
Her
Just
hands.
stick into this right now.
Okay.
You can cut right here, but you run a risk if you cut it too big, then you expose all your padding. Another thing is if you go and you're like, oh, I cut it too short, you could come this way a little bit. Just make sure it's not super tight. Give me a wrinkle.
I'm like thinking I'm doing this. It's weird. It's a good illustration of what happens when you move, when you have fiberglass on though, right? Look,
Yeah.
right? I'll do that. So you need 3 passes through the thumb at a minimum. Teenagers will break it anyway.
To
but-
make a huge water mess on your carpet.
So she's already got 1 pass, so now she's gonna do the second and third. So you cut it like 1/4 of an inch, come through, anchor it at the base of the thumb again. Oh, you do 2, okay.
Just like it sticks to each other.
Yeah.
This one, if it's not big and bulky, you can fold it over so it's not sharp on them.
If you fold back too much though, right here, you'll lose strength in the cast and they'll break through your mold around your thumb. So you need some right here.
And then you just don't want to end where you would have to kind of mold so they can't pull it off.
Can I sign this out?
So this right here is not gonna bug me, believe it or not. Like, this doesn't matter. As long as I can fully abduct my thumb, which I can, it's fine. And you can see in the front, I can fold my fingers over, right? And on the side, and I can make a fist, right?
Yeah, you're way low on that lateral side. That's great on that ulnar
Yeah,
side.
you need
Yeah.
to make sure you're below that metacarpophalangeal knuckle by the way.
Yeah,
so
right
they
here.
can't-
And when you're doing this, that's on the far side of you. Like, I always find myself a little high over there, and people are over there yanking it down for me. So, yeah, look at me making wrinkles, guys. Bad news.
Do you want to cut that off before it dries, or do you want me to grab the press?
Any questions about this? So 3 passes through the thumb. Just make sure you pad the thumb in a way that you can remember.
Would you ever do a cast like that if you had buckles on both thumbs that were stable?
You can still do a brace for both bone buckles.
So then when would be the purpose of doing this? Just when parents want to cast?
For a buckle fracture, if they want to cast. We do these for literally every other wrist fracture.
Like displaced radius. That they,
Yeah. Salter 2 disarray fractures, we see a lot of those.
But we're gonna send all of those to you anyway, right? So are there any things that we would do in clinic that would require this short arm cast?
I don't think anything you guys do requires it, but like you said, if there's somebody who comes in with a buckle and they just aren't hearing that the brace is really the right thing to do, this is the next thing.
I kind of feel like most teenage boys, they won't keep the brace on, so I'm like, you're a terrible patient, you're probably getting a cast.
Yeah.
Because at least you can't, that's harder to take off.
Yeah. The reality is, with a true buckle fracture, if you do nothing, they do okay. That's the FORCE trial that just came out of the UK. They wrapped them with a soft bandage, and it seems like it works fine.
I don't know if you've met Cammy's boys.
Aflac is gonna kick me off.
Yeah.
They're like, you maxed out, you're in place.
So, yeah, I mean, I get it. I feel the same way about teenage boys, and if I'm worried that they're not gonna wear it, then I absolutely will cast stuff that I don't normally cast. So, yeah, reasonable. Or if they want to play football, right?
Yeah.
Or soccer. I think if you're going to finish out a soccer season with a buckle fracture, you probably ought to cast them.
Then are you okay, how long after they're in the cast to go back to resume, like to play soccer or whatever?
I let them go right away.
No
Yeah.
waiting period.
Nope.
It's gonna be good news for lots of kids.
Yeah.
Try not to like yank you all over the place.
Do you, from a billing standpoint, do you bill it the same way whether you put them in a splint or you put them in a cast?
It
Other
is.
than to the casting itself, but like, is it still the same level visit?
No, it's one of the reasons. Yeah, it's a great question, actually. So, if you put a cast on, you automatically fall into fracture care, right? And so, fracture care for 25600, which would be this, is about in our office $690, $700 roughly. It's a lot of money. Yeah, that's what we think. So if you do a buckle fracture with a removable brace and it's one visit, one brace, and they don't come back, which is what most people are doing because you don't need to come back, you don't need follow-up for that, then that bills at about $250, $300. So it's anywhere from a third to a half as much.
Well, and if they come see us, we're like a half of that, right? 'Cause we're billing it like a level 4 visit.
Yeah. So yes, the cost is significantly different to not bill fracture care for those.
And I don't know if you're gonna get into this a little bit later, but it would be helpful if you could just give us sort of a handful of fractures that need to be seen that day, right, as opposed to need to be splint. I mean, they both need to be splinted, but need to be seen ASAP or need to be seen, next week.
Yeah. Which is kind of a whole separate discussion.
That's what I'm just, you can just like list off the top 5, the top 10 list of those.
Can you summarize your orthopedic residency?
Under 30.
Yeah. Anything that needs a reduction, it has to go to the ER if the alignment's not okay. Anything that needs surgery probably just ought to get sent that day, or at least, a phone call. We've got time in our OR schedule that all of us cover 2 or 3 rooms a week of afternoon, kind of what we call cold trauma, so like ankle fractures, type 2 elbows, stuff that doesn't have to go that night, and that might be more of stuff, like the kind of stuff you guys see that isn't splint and cast later. So, Bree's gonna do a ulnar gutter on me, but
So bones sticking out.
goes to the ER.
Okay, gotcha.
White hand, that goes to the
Yeah.
ER.
Okay. I do.
So, do you guys see okay?
Mm-hmm.
Here,
You guys
here.
do waterproof?
No.
We,
they don't.
Awkward topic.
Yeah, we use cast padding that is marketed as waterproof, that is decidedly not waterproof. So.
We don't use Delta Dry if that's what you're asking.
And we don't use the mesh stuff, is that Delta Dry? We don't
Yeah,
use
we
the
use
Gore-Tex.
We use the Delta
Yeah, we have not, we've
Seen
peeled
too
layers
much.
of skin out
I
of.
think the
that,
reason
so.
that the kids have it that way is I don't think they're submerging the cast, they're not drying it afterward, and that's like the big caveat you have to tell them is you have to do the cool hair dryer and dry it,
Yeah,
and that's what you have to do that.
yeah, I mean, at that point, you may as well just get a cast cover.
Yeah, or that, they go to the beach
Yeah.
thinking we're good, and then we're
Bunch
pulling
of sand
sandpaper out.
down there. Yeah.
So you guys do no waterproof, but you recommend like a
We,
special cast
we
cover?
say it's water resistant, clean
Yeah.
water only, but it can, if you have eczema, psoriasis, anything like that, not to get it wet.
Yeah, the eczema kids who get their cast wet look awful.
You're not using that same pattern of dash, right?
Oh, I didn't see that.
We didn't bring any of our waterproof
I
pads.
They
haven't
use
seen
theirs,
that.
they use
Yeah.
this
Ours
pattern
is like
for
a
their
wet
cast.
dry padding.
Yeah,
So
it's got
3 and
black,
wet dry.
it's got black lettering on it, I can't remember exactly what it's called, but I tell kids if you're gonna get it wet, rinse it out, and it takes 2 hours to get dry with a hair dryer, and if you frame it that way, and then you sort of end with, or there's this cast cover you can get and use that when you're showering, everybody's happy to use a cast cover.